I'd like to thank the judges for giving me this opportunity. So my paper for today is Neuro-ophthalmic manifestations of acute demyelinating encephalitis in Indian pediatric population.
Excuse me, slides.
It's not moving, sir. So ADEM is characterized by encephalopathy with multiple CNS demyelination, and its diagnosis is based on clinico-radiological correlation and exclusion of conditions that mimic ADEM. So the objective of the study was to analyze children diagnosed with ADEM presenting with neuro-ophthalmic manifestations. So we looked into the data between June 2018 and May 2023. We included children less than 17 years of age who had presented to a neuro-ophthalmic clinic with acute and previous history of ADEM and did not fulfill the diagnostic criteria of MS, and who had come for follow-up at least once post-treatment. The sample size was 14 patients. It was a retrospective analysis, and the following data was collected. All patients were treated with IV followed by oral steroids. There was a female preponderance, 64% of them were female. The mean age of presentation was 8 years. Mean follow-up duration was 37 months. And we noted that 8 out of the 14 patients, that is 57%, had presented first to the ophthalmologist. And the remaining 6 patients were referred by neurologists to the ophthalmologist for opinion. Looking into the clinical characteristics, viral prodrome was noted in 8 out of the 14 patients. Mean interval between the ADEM and the visual symptom was noted to be 30 days, and the most common neuro-ophthalmic manifestation was optic neuritis. The most common ADEM symptom was noted to be headache. The mean vision on presentation was logMA 1.1, but still in the last follow-up, the mean vision or mean visual outcome was logMA 0.4, and the p-value was significant. And all patients had MRI brain and orbit, and MRI brain showed ADEM-like lesions in all the 14 patients, and MRI orbit showed T2 signal in 12, and 2 had contrast enhancement, and MRI spine was done in 4 patients, out of which 3 had hyperintense signal. And this is a MRI of a patient, one of a patient who had ADEM-like lesion with optic neuritis. 9 out of the 14 patients had undergone both NMO and MOG antibody, and 4 patients had undergone only NMO antibody, and 1 patient did not undergo both NMO and MOG antibody. We noted that 5 of them were MOG positive, none of them were NMO positive, and seronegative. Both NMO and MOG were negative in 4 patients, and 4 patients NMO were negative, but their MOG status was unknown. And this group where MOG status was unknown, they were all classical ADEM followed by optic neuritis with a good visual prognosis. And the other group, the seronegative group, 1 patient was classical ADEM followed by AN, followed by optic neuritis, but the other 3 had a varied presentation. I've tabulated them here. 1 patient had presented with paraplegia secondary to myelitis, and we noted that all 3 of them had a very poor visual prognosis in the last follow-up. We noted that 6 out of the 14 patients had relapse in either the form of optic neuritis. 5 had optic neuritis and 1 had a recurrent ADEM. The average relapse interval was noted to be 3.7 years, and 2 patients had relapsed within 2 months, and obviously these 2 patients had relapsed when the oral steroids were tapered. MOG antibody was noted to be positive in 3 out of these 6 patients who had relapsed, and 4 out of the 6 patients had residual ophthalmic symptoms either in the form of visual impairment, persistent field loss, and pupil abnormality. And all these patients who had relapsed had escalation of the treatment, and they were put on maintenance therapy. Moving on to the discussion, ADEM is a rare polysymptomatic demyelinating event which can present with vision loss secondary to optic neuritis and encephalopathy, which can manifest as headache, behavioral change, alteration in consciousness, or even lethargy. There's a slight male preponderance in ADEM according to literature, but our cohort had a female preponderance. The probable reason could be the association of pediatric optic neuritis with females. And the most common neuro-ophthalmic manifestation in ADEM was optic neuritis, which is very similar to the data published so far. And current studies have also noted that ADEM-ON is a distinct clinical entity. 3 of our patients had a cranial involvement due to midbrain disease. And we noted that there's a strong association with MOG antibody. In our cohort, it was 35%, and the subset who were MOG negative, we were not able to classify them under any defined disease entity. But the sample size is too small to comment on its significance. The visual outcome was very good, and the prolonged inter-attack interval, especially in the MOG positive cases, denotes that they need a long-term use of steroids or immunosuppressants. And we also noted that none of the patients had relapsed when they were on maintenance therapy. But of course, we need further studies to confirm these findings. So the limitation of a study was very much similar to other retrospective analysis, and I would like to conclude saying that ADEM is a very rare entity which can present to ophthalmologists, and everybody should be aware of this condition. Optic neuritis is the most common manifestation of ADEM, and they have a very good prognosis. 1/3 of them can be MOC positive. With a small cohort and a poor follow-up, it's difficult to come to a conclusion regarding the prevalence of pediatric MS, and this merits further studies on ADEM in Indian population. Thank you.
So how many patients of ADM who presented with the optic neuritis, later on they manifested encephalopathy?
Yeah, ma'am. We had 8 patients. 11 patients were optic neuritis. And we noted that 8 of them had presented first to the ophthalmologist, that is vision loss.
They didn't have any associated neurological symptom at all?
Retrospectively, on asking the history, on the file, we saw that they either had headache, some lethargy, a month back, 3 weeks back, a viral prodrome, those were noted. And then the MRI was done for optic neuritis, which picked up ADEM-like lesions.
Multiple,
then we had referred to the neurologist for treatment.
Is this pre-COVID or post-COVID era?
No, this was 2018. Yeah, this was during the same time.
During the same time.
Yeah, 2018 to 23, maybe
The
slightly before the COVID also.
Those vaccines?
One patient had vaccination history, only one of our patient, which was a measles vaccine.